see the management of preterm labor. Management of preterm labor is indeed an important short note. So it's very important. Now first we are going to look for if there are any premature uterine contractions. Now if there are any premature uterine contractions, we can divide it as either it can be a threatened preterm labor or it can be an established preterm labor. Now what should we do if it is a threatened preterm labor? So if it is a threatened preterm labor, we need to first hospitalize the patient and then observe for cervical changes. So after observing the cervical changes, we also need to evaluate for urinary tract infection. And then we will be doing a high vaginal swab, and also we will be looking for the fibronectin levels. And the next thing we'll do is ultrasound assessment of the cervix. So what all investigations are we going to do? So if it is a case of a threatened preterm labor, first I will hospitalize. I will look for the cervical change, evaluate for UTI, do a high vaginal swab, look for the fibronectin levels as well as the ultrasound assessment of the cervix. And now these were the investigations, and now what is going to be the medical management? First I'll be administering antenatal corticosteroids. I will give antenatal corticosteroids. Hydration therapy is given. Infections if present should be treated. Progesterone therapy. Progesterone therapy in high risk patients and in those with a short cervix must be administered. So what all medical management? Antenatal corticosteroids, definitely corticosteroids for fetal lung maturation. Hydration therapy, and infections, if there are any infections, they must be treated. Progesterone therapy in high risk patients and those with a short cervix must be given. So then if there are no cervical changes and if there are no contractions, no cervical change, no contractions, I need to follow a normal antenatal care. Okay, when there are no cervical change and no contraction, I will be following a normal antenatal care. Now, if it is an established preterm labor, so if it is an established preterm labor, I can either suppress the labor. Okay, I can either suppress the labor. If when I can suppress the labor, I can suppress the labor if gestational age is around 28 to 34 weeks. Then I have a possibility of suppressing the labor. And if the live fetus with no signs of fetal distress, so there is a live fetus with no signs of fetal distress, and the cervix should be less than 3 centimeter, no medical or obstetrical contraindications. There must be no kind of medical or obstetrical contraindications, and as well as no intrauterine infection. Okay, this is when I will suppress the labor. Now, how can I suppress the labor? So after suppressing the labor, I will be giving the medical management will be tocolytic drugs can be given, antenatal corticosteroids is given, magnesium sulfate for neuroprotection is given. I will be treating a urinary tract infection, and I will plan in utero transfer if necessary. Okay, tocolytic drugs, antenatal corticosteroids, magnesium sulfate for neuroprotection, treat UTI, plan in utero transfer if necessary. And then I will do a follow-up. So follow a normal antenatal care with surveillance. Follow a normal antenatal care with surveillance, and delivery should be at, I will be delivering at 37 weeks. Now, if there are conditions that are warranting an immediate delivery. So what are the conditions warranting an immediate delivery? First is the cervix is more than 3 centimeter dilated. There is fetal death or congenital anomalies. There are it is a clinical amnionitis case. Okay, clinical amnionitis is there. And maternal disease. Okay, maternal diseases requiring immediate delivery, and fetal conditions necessitating the immediate delivery. So all these are the conditions warranting an immediate delivery. So what will I do then? I will be conduct a preterm delivery in a tertiary care center. So these are the three scenarios. So threatened preterm labor, basically there will be no delivery at all. I'll just follow normal antenatal care after giving hospitalization and doing the investigations and giving the required medications and all. And if there's an established preterm labor, I can either suppress the labor or there will be, if at all there are conditions warranting immediate delivery, I will conduct a preterm delivery in a tertiary care center. So this is the management of preterm labor. So management of women with warning signs of preterm labor. So how am I going to do the management of women with warning signs of preterm labor? First, an initial evaluation of the women should be conducted. Okay, an initial evaluation of the women should be conducted. Urine as well as high vaginal swab should be sent for investigation. And then ultrasound assessment, very important, ultrasound assessment for cervical length is must. And if the woman is febrile, and if the woman is febrile, the source of infection should be identified. It's very important to identify the source of infection. Bed rest is important. Hydration therapy with 1 liter of 5% dextrose. Hydration therapy is given. And then antibiotics. Antibiotics for infection or premature rupture of membrane is given. Then antenatal corticosteroids is given. Prophylactic tocolytic drugs is also another important medication we need to give. Prophylactic tocolytic drugs. Progesterone therapy again is important. So whether progressing to established labor should be observed. Okay. So whether progressing to established labor or not, it should be observed. If there are no further, if at all there are no further uterine contractions or cervical change following observation, the woman is discharged for normal antenatal care. So we need to look for uterine contractions and cervical change. Carefully we should observe. If there are no changes, then the woman is discharged for a normal antenatal care. Now moving on to the management of women with established preterm labor. So management of women with established preterm labor is first, immediate delivery or suppress the labor. These are the two options. Either I can conduct an immediate delivery or either I can suppress the labor. Okay. So these are the two options if the woman is with established preterm labor. Now suppressing labor. Suppressing labor is a live fetus with no signs of fetal distress. When can I suppress labor? There is a live fetus with no signs of fetal distress means I can go for this option, suppressing labor. And very important criteria, the cervix should be less than 3 cm. No medical or obstetrical contraindication such as preeclampsia or antepartum hemorrhage. No intrauterine infection. Then administering tocolytics is very, very important. What are the tocolytics is also another. Tocolytics alone can be a short note. So tocolytics are example beta adrenergic agents. What are the beta adrenergic agents? Retardin, salbutamol, terbutaline. So the three main beta adrenergic agents used as tocolytic is retardin, salbutamol and terbutaline. Then we have calcium channel blockers. The very, very important calcium channel blocker used as tocolytic is nifedipine. Next is prostaglandin inhibitor. Prostaglandin inhibitor like indomethacin. Magnesium sulfate, nitroglycerin transdermal patch, oxytocin receptor antagonist, that is atosiban. So these are the tocolytics. All the tocolytics are going to be administered for a period of 48 to 72 hours. 48 to 72 hours to give time for corticosteroids to act. So a must thing to be known is all the corticosteroids, all the tocolytic drugs are administered for a period of 48 to 72 hours to give time for the corticosteroids to act. Now, what are the strategies to improve neonatal outcome? So there are certain strategies to improve the neonatal outcome. First is the neonatal care, very important. Then corticosteroids, where two doses, okay, of 12 milligram beta-methasone is given. 12 milligram beta-methasone, okay, intramuscularly is given 24 hours apart. Two doses 12 milligram beta-methasone 24 hours apart, or 4 doses of 6 milligram dexamethasone intramuscularly. This is 24 hours apart. This is 12 hours apart. 12 hours apart. Okay, 4 doses, either 2 doses 12 milligram beta-methasone IM 24 hours apart, or 4 doses 6 milligram dexamethasone IM 12 hours apart. This is the dose. And magnesium sulfate for neuroprotection is given. A 4 gram loading dose of 10 to 20% solution is administered IV over 30 minutes. So a 4 gram loading dose, okay, a 4 gram loading dose of 10 to 20% solution is administered IV over 30 minutes. This is followed by maintenance of IV infusion of 1 gram per hour over 24 hours, and antibiotics are given. Now, how to do the conduct of preterm delivery? So, how to conduct preterm delivery? So, first will be your intrapartum management. So, under intrapartum management, first is precipitate and prolonged labor should be avoided. So, any kind of a precipitate or a prolonged labor should be definitely avoided in the intrapartum management. And maternal hypotension should be avoided. Okay, maternal hypotension. It is hypotension should be avoided. Then hyperstimulation with oxytocin drugs should be avoided. Okay, so hyperstimulation of oxytocin drug, hyperstimulation should be avoided. Narcotics, sedation, analgesics should be avoided. Narcotic, sedation and analgesics should be avoided. The membranes should be kept intact as long as possible to prevent infection. Why are the membranes kept intact? To prevent infection. Then cardiotocography. So cardiotocography may show abnormal findings. A neonatologist should be available, okay, definitely at the time of delivery. Episiotomy may be required when the fetal head reaches the perineum. So when the fetal head reaches the perineum, so episiotomy should be required. And the use of outlet forceps may be beneficial when epidural analgesia, okay, when epidural analgesia is used, and if there is a poor voluntary expulsive effort. Whenever there is a poor voluntary expulsive effort in the second stage of labor, this is when outlet forceps can be used. Vacuum, okay, vacuum should be definitely avoided. So this is the intrapartum management and conduct of a preterm delivery. Now let's look at another important short note, frequently asked short note. What is PPROM? So PPROM stands for P for preterm premature rupture of membrane. Okay, PPROM stands for preterm premature rupture of membrane. So first let's look at the definition of PPROM. So PPROM means rupture of membrane before 37 weeks of gestation and before the onset of delivery. So any rupture of membrane that is occurring before 37 weeks of gestation and before the onset of labor is known as preterm premature rupture of membranes. It accounts for 50% of all the preterm births. Now, what are the causes of PPROM? The causes of PPROM are increased intrauterine pressure. So, increased intrauterine pressure is the main cause for PPROM. Infections is another important cause. Procedures such as amniocentesis and fetoscopy. Procedures such as amniocentesis and fetoscopy is another major cause for PPROM. Inherent weakness in the membrane as a result of collagen deficiency. So, inherent weakness in the membrane as a result of what? Collagen deficiency can be a cause of PPROM. Now, the diagnosis of PPROM. How are we going to diagnose PPROM? So, first is history of gush of fluid is going to be given. Okay. So, first main thing which out of which we will be diagnosing PPROM is the patient will give a history of gush of fluid. Sterile speculum examination should be done to visualize the leakage of amniotic fluid. So, by doing a sterile speculum examination, we can visualize the leakage of amniotic fluid. Smear the fluid under microscope. So, we need to, after doing a speculum examination and visualizing for leakage of amniotic fluid, we will be taking this fluid and we will place it in a smear under the microscope. So, what you can see in the smear? Floating vernix can be seen. Very important finding. Floating vernix can be seen in the smear. Simple dipstick assessment of pH will be more than 7.1. Okay, it will be basic, base in nature. Nitrogen test is done, Ferning test is done, and ultrasound examination, fetal fibronectin. So, how are we going to diagnose PPROM? History of gush of fluid, sterile speculum examination to visualize the leakage of amniotic fluid, smear the fluid under the microscope, you get a floating vernix. Simple dipstick assessment is going to be basic, more than 7.5 pH, 7.1 pH. Nitrogen test, Ferning test, ultrasound examination and fetal fibronectin. Now, what are the complications of PPROM? So, how complicated is this condition, PPROM? First important complication is chorioamnionitis. Chorioamnionitis is the first important complication. Second is abruption. First is chorioamnionitis. Second important complication of PPROM is abruption. Third is increased induction and cesarean section rates. So, the induction rate will be more. The labor will be induced very soon in a PPROM. So, the induction rate is more as well as the cesarean section rate is more. Puerperal sepsis is another important complication of PPROM. Puerperal sepsis. And the last one is the fetal complication. The fetal complication will include pulmonary hypoplasia, fetal and neonatal infection, and cord compression in labor. So, the fetal complication will include the pulmonary hypoplasia, fetal as well as the neonatal infection, and cord compression in the labor. Now, let's move on to the management of PPROM. So, how are we going to manage a case of PPROM? Management. So, first we'll have to confirm the diagnosis. We need to confirm that this is a condition of PPROM. How will we confirm? We need to first assess. Okay, and assess, we need to assess for the risk of infection. What is the risk of infection? Okay, and signs of infection should be assessed. Pregnancy complications, if any, fetal distress or malformation is there or not, gestation more than 34 weeks. More than 34 weeks. So, after confirming the diagnosis, we need to assess the risk of infection, signs of infection. We need to look for pregnancy complication. We need to look for fetal distress or malformation and gestation more than 34 weeks. Okay, we need to assess for all these, and whether it is present, all these are present or not. Okay, if it is not present, so if it is not present, then we need to move on to conservative management. Conservative management. So conservative management includes, first is conservative management, we will be giving betamethasone. Betamethasone 12 milligram. Again 12 milligram betamethasone, 2 doses intramuscularly 24 hours apart. Initial intravenous antibiotic is given. Okay, wow. So initial intravenous IV antibiotics is given, followed by oral antibiotic therapy. Initially IV antibiotic will be given, followed by oral antibiotic therapy. Then monitor for signs of infection. So we need to monitor for any kind of signs of infection. Monitor the fetal well-being. We need to monitor the fetal well-being. Deliver at 34 weeks or earlier if there is infection or fetal distress. So the conservative management includes betamethasone, intravenous antibiotic followed by oral antibiotic therapy, monitoring for signs of infection, monitoring the fetal well-being, and delivery. Okay, we need to deliver at 34 weeks or earlier if at all there is any infection or fetal distress. This is the conservative management if it is no, all these factors are not there. Now whether there is a risk of infection or pregnancy complication or fetal distress or the gestation is more than 34 weeks, okay, then what we need to do? We have to move on to active management. So what does active management include? So the active management include induce the labor pain. Okay, we have to induce labor pain with oxytocin if there are signs of infection and then give antibiotics. So first we will be inducing. Okay, the active management is to induce the labor. How are we going to induce the labor? With oxytocin. And then what should we do? We need to assess for any signs of infection and then give antibiotics. So this is how we will manage PPROM. So yeah, we have come to this chapter. We have come to an end of this preterm labor. We have saw and also we learnt about PPROM. So if you like this video, please do like, subscribe and share this channel. And especially if you want to watch and view more videos in Mudaliar Menon lecture series, do subscribe this channel. Thank you.